Plus, we are not so bad. We are lucky enough.
And I want all attenders to close their microphones because we hear some voices, extra voices there.
Yeah, please mute your microphones because we can hear everybody.
Please. Now, Nikolay, your topic is minimally invasive spinal surgery in a center with limited resources. We may start. We are listening to you.
Okay. Thank you so much for the opportunity. It's my pleasure to be with all of you. And again, this is something in the COVID era, virtually, and we can still share ideas. So I was asked today to present to you on minimal invasive surgery and to tweak it from the perspective of center where not everything is available. I'll try to do that today. Before I start, at the minute I practice and I live in Northern Ireland, and I practice in Royal Victoria Hospital in Belfast. Belfast is a beautiful city, and if you haven't visited, you have to visit. This is where is Belfast, on the small island, and this is the big island, and all that here is United Kingdom and Northern Ireland. So let's start. This is the hospital where I work, obviously a bit more modernized now. This is the university where I'm associated with. And this is the modern anatomical facility that we have started recently, and we use it for courses, and probably we'll have chance to organize another course and to have you there when all the COVID madness is finished. So I would like to continue with that slide, just shortly show you the evolution of the spinal surgical techniques. As you can see here, we have the transperitoneal anterior approach as early as 906. And then we have the first PLIF procedures available from 1944. If you go further, you can see that we have the first cases in the beginning of 90s. And the minimal invasive surgery started to develop in late 90s and early 2000s. So we have, speaking about minimal invasive surgery, we speak about relatively new technique. But despite that, you can see now that we have minimal invasive options. On the right side of that table, we have minimal invasive techniques for nearly every condition in the spinal surgery. And as per the data, company data that I managed to get from different companies, about 30% of the surgeries are done in a minimal invasive fashion in the US, but only 3% of the surgeries are done in a minimal invasive way worldwide. So we have still what to do in order to get more people, more surgeons on board with the minimally invasive techniques. So before I start and before I continue, let me give you a few concepts. So the surgery as a concept, as we all now know, is we have to create a surgical path, which we call approach. Then we have to approach the surgical target. We have to perform the surgery. And then we have to close the surgical path to recover the normal structures that we split to create the surgical path. Unfortunately, that is not always as good as we like to be, and we always leave behind an active tissue in form of scar tissue, and so we leave footprints. So a basic tenet of the surgery is to effectively treat the pathology with minimal disturbance of the normal living tissues, so leaving smallest possible footprints. This is what the minimal invasive surgery is providing. It's a relatively new type of surgery that will give you opportunity to achieve your goals with significantly less footprints. As you can see here on these pictures, in the middle is the effect that you're chasing. Obviously, it's a no-brainer if you would like to, if you can achieve it from this starting point or from this starting point. If that's my back, I would like to have it from this starting point. So if we have to define the minimal invasive surgery, this is a surgery that will give you less collateral tissue damage, that will give you measurable decrease of morbidity, faster functional recovery, and you still reach the intended surgical goals. This is all defined in this paper very nicely, and I recommend, if you haven't read it, and if you're interested in minimal invasive, to read it. So with the next slide, I will tell you that we actually what are the principles of the minimal invasive surgery. This is to avoid normal tissue injury by muscle splitting techniques, limited width of the surgical corridor, using non-anatomical planes, and not disturbing the tendon attachments of the muscles. The results will be direct decompression, indirect decompression, muscle sparing, interbody fusion, and posterolateral fusion. So I dare to tell you that we all do that surgery. Nearly all of us are performing these anterior cervical approaches. And if you think the anterior cervical approaches, they comply with these principles. We use a relatively avascular plane. We don't disturb the muscles. We perform the surgery and then we close. And this is a perfect example of application of the principles of minimal invasive surgery. And this is demonstrated by this paper. I like to quote this paper coming from US, Ed Benzel and team. They basically examined a big number of patients, as you can see here, and they compared surgeries which achieve similar goals with posterior or anterior approach. And the conclusion is that if you basically can go anteriorly, that's going to give you better results. And this is because you disturb less muscles. So muscles are very important, and we realize that more and more. And this is one of the main principles of minimal invasive surgery. Keep the muscles intact. Why the muscles are important? As you can see on these pictures, you have multiple layers of muscles which are supporting your spine. And that is why I can say that your muscles are as much important for your spine as these ropes are important for this sailboat. And there is now numerous of researchers that support that thesis, that if you disturb your muscles, you disturb the whole biomechanics of the spinal column, and then you create problems for the patient and as a surgeon for you as well. So minimal invasive surgery, why we have to complicate that? Because by performing minimal invasive procedures, we reduce the infection rates, we reduce the blood loss, the post-operative pain is less, we reduce the need of instrumentation and fusion. On a long run, the minimal invasive surgery appears to be cost effective. So your managers will be happy as well. Patients like it and they ask for that. And the minimal invasive approaches will allow you to operate patients which you would otherwise not consider, like morbidly obese patients, highly functioning individuals like sportsmen. But unfortunately, like anything, the minimal invasive surgery has its own pitfalls. And among these, we will discuss now long learning curve, radiation exposure, equipment demand, technique that is sometimes challenging and difficult to get in our hands. So let's start further. Long or steep learning curves. We quite often hear and listen about the steep learning curve. So why the learning curve is steep? Quite many people have difficulties to explain why the learning curve is called steep. And this is well demonstrated on that curve now. So as you can see here, on the x-axis, on the horizontal, you have the expertise, the levels of your skill, the level of your skills. And on the y-axis here, you have the time that you need to achieve the skills. So as you can see, from newbie to hobbyist, you need X time to achieve, But from hobbyist to expert, you need more than twice the time to achieve the hobbyist. So this is why the curve is steep, because from being hobbyist to being expert, you have to invest times more than you have invested so far. There is a good research coming from Paulo Pereira and team from Portugal. And he tells you that basically if you start doing minimally invasive procedure, you need about 50 cases to achieve your 90% milestone. And this is basically being a hobbyist. If you want to achieve 100%, you have to invest a lot more time. And probably you have to do twice or maybe 3 times more than the patients that you have operated so far. How you achieve that? By good mentorship. You have to have good foundation. You should not start doing and developing minimal invasive procedures if you don't know the basics, if you don't have the basic surgeries in your hands. And you have to be prepared to be persistent, and you have to be prepared for complications. So another big problem for the minimal invasive surgery is the radiation exposure. We all know that with the standard, with classical approaches, we have widely open wounds. We have all the anatomical landmarks that we need. Unfortunately, that is not possible for the minimal invasive surgery. If you would like to apply the principles of the minimal invasive, you cannot open widely the wound, and you rely quite often on the X-ray anatomy. Of course, the best to do that is if you have the modern technology. Let's say you have a modern O-arm in your theater, you have even more modern machines which are now available on the market. However, this is not the case with many of us, and that's why I would like to comment a few slides on the radiation exposure and also the principles of the radiation protection that will be of crucial importance for you in order to perform your minimal invasive surgeries safely for you and for your patient. Good research from Franzen from 2011 tells you that you need about 8 seconds screening time to put an open screw compared to about 27 seconds for minimal invasive screw. So that's a big difference, about 3 times difference of the radiation exposure. And this is quite a lot. And many people feel this is unsafe. But if you know the principles and if you know how to do it, it can be safe for you and for your patient, and you still can achieve your goals. So this is very good diagram that shows that you have to choose your site widely, like anything in life. You have to choose your site widely. You can see here the surgeon that is sitting on the side of the X-ray tube is getting 4 times more radiation comparing to a surgeon that is sitting on the side of the image detector. And why is that? Because we normally don't get the direct beam, but we get the scattered radiation. And it's well known that the scattered radiation is more on the side of the X-ray tube, and it is significantly less on the side of the image detector. Another good picture that is showing you that with distance, the radiation drops significantly. So it is important for you to have your protection gear on, but the most important thing is for you to be as far away from your surgeon, from your patient as possible. And you can see here that only 30 to 60 centimeters away from your patient, the radiation exposure drops significantly. So this is something that you can easily do. You can dance back and forth when you're operating your surgeon. And before you ask your radiographer to X-ray, you have to step back. Stepping back even with one step gives you significantly less radiation comparing to if you are right next to the patient. So another diagram here, it shows you what is the best way to work on an AP views. You can see that leaving the image, the X-ray tube above the patient gives you significantly higher radiation comparing to leaving the X-ray tube under the patient. And this is the right way to do. If you leave the X-ray tube above, you have significant radiation of X-ray sensitive areas like your thyroid, like your eyes, and that is not recommended. This is very good research that I wanted to show you to demonstrate the importance of the distance. This is Kim from Korea and team. They have done a very interesting research. They have wrapped a X-ray detector with a lead glove, and they put it right on the patient, that is A. And then another detector that is away from the patient, only 20 centimeters away from the patient, and is not wrapped with the lead glove. So they found that A has significantly higher dose despite it is wrapped with a lead glove, comparing to B, which is not wrapped with a lead glove, but it's only 20 centimeters away from the surface. So this is a big drop of dose only by a simple measure, stepping one step back. And this is something that you have to implement in any possible case when you perform your surgeries. You have to avoid, by all means, this situation where you can see your fingers on screen. And if possible, you have to use long instruments. Like here, I am holding my Jamshidi needle with a long instrument, and that is helping me to stay away and to reduce my dose. So special equipment is important when you would like to do your minimal invasive surgeries. It is always good if you have these special fancy tubular retractors. It is always good to have your OR in your theater, a special dedicated spinal table like this Jackson table maybe with 3D C-arm. A 3D C-arm, but unfortunately, not all of us have this luxury. So that's why you have to sometimes think out of the box. You should not stop yourself from trying new things and trying to do minimal invasive approaches. You have to just be creative, and let's see what we can do about that. So this is how I started my my minimal invasive approaches, and this is how I still quite often do it. This is a normal operating table. Of course, we said that it's good for you to have the Jackson table or the Allen table that will that is a dedicated spinal table. But in case you don't have it, that is not a reason for you to not try something new. This is a normal operating table. Every operating table will give you good AP and lateral views. And you can try to start your surgeries with what you have. If you are possible to modify your equipment, for example, this is a normal table that was modified with carbon fiber extension. And with the carbon fiber extension, I have nearly the same experience that I will have with the dedicated spinal tables. It is important when you start your surgeries, whatever table you have, especially if you have one of these normal operating tables, you have to prepare the patient for long surgery. Means you have to do a you have to do a good padding of the pressure points. Special attention to the femoral region, especially if you do lumbar surgery, because that can give you troubles. For example, when I started, before I apply this foam under the femoral region, I had a few femoral neuropraxias, which initially I was not possible to explain why. But then, if you think with a long surgical times and with all the hammering, and with the femoral nerve above the crest of the pubis, and then you can explain that. So you have to, a good idea if you use one of these not dedicated tables, but any table, is to check your main AP and lateral positions before you cover and before you drape your patients, because that will give you a bit more certainty that you will have the images that you need when you need it later. And it's a good idea to collaborate with your radiographer and to even do an induction, what exactly you want him to do before you start your surgery. A good idea is to work with one of the same radiographer, but not always we are possible to do that. So induction prior to surgery and checking your positions is something that will save you from troubles.
Dear Nikolay,
yes.
Can you please make your PowerPoint smaller and then open again? Because there is a red line on the screen.
Yes, I have noticed.
Produced by your computer.
I have noticed that, but I am afraid that if I do many things, my my Zoom may crash again. So okay. I have.
Okay.
I have.
That's fine. We must.
I'm sorry about that.
Yeah.
This is. I think this is not coming from me. This is coming from Zoom, because I had recently, I participated in another Zoom meeting, and it was the same thing there. So I think it's a glitch from the system, really, not from my computer.
I think it's a very good trick to don't be copied, right?
Yes.
Thank you. Okay, please go on.
Okay, so the retractor systems that you have is that you use is also important when you attempt to do minimal invasive surgeries. There is now numerous of minimal invasive retractor systems, as you can see here. But what if we don't have that? If you don't have that, again, we can improvise. This is what I currently use, and this is what I started using in the beginning. I didn't have dedicated minimal invasive retractor. I have a simple McCulloch retractor that probably is available in most of the operating theaters. The only thing that I have done initially when I was starting is I have modified it by ordering extra long blades. So I have from 6 centimeters to 14 centimeter blade here, and I can operate very, very big patients with that. So the McCulloch retractor is giving me, if not the same, close to the experience that I have with all these fancy tubular retractors. Despite now I have, I can have access to nearly the majority of the minimal invasive retractors that are on the market. I still use the simple McCulloch retractor because it is good and simple to use. And I'll show you pictures of that. So you can see here, this is the view that you see from a simple, when you use a simple McCulloch retractor. You see here that a large blade is normally medially, and it's docked on the facet. And on the lateral side, I just initially I was using another blade, but now I use just a simple simple hook. And one can argue that the trauma that this retractor is giving to the tissues could be even less comparing to the tubular retractors, because the area of contact here is maybe about 20 millimeters. And if you use 20 millimeter diameter tubular retractor, the area of contact will be more. It will be at least 60 if we calculate it. So minimal invasive retractor is important for you to have. If you can have your tubular retractors, it's good to start. But even if you don't have any minimal invasive, any spinal retractor, nearly any spinal retractor can be applied, and you can start using the principles of the minimal invasive surgery. And that is if you develop a will-say approach and open it with anything that you have in order to perform your surgeries. With this, I can do many things. With this retractor, I have done T-lifts, I have done decompressions, which you can go from laterally to medially based on the tilt of the retractor. I can do cages with the Wilsey approach and with the help of this retractor. So the retractor system is important. My message to you is retractor system is important for you to have, but if you don't have dedicated MIS retractor, you can start with anything that you have on your disposal. I remember one of the first time when I went abroad and I had to do a live demonstration of minimal invasive T-lift. It appeared that in the theater there was no retractor, no McCulloch, nothing. So I have done the first T-lift with simple self-retaining retractors. And this was possible. So another pitfall of the minimal invasive is the techniques that have been used, and many authors report that the technique is really difficult to achieve in terms of proper screw placement, the precision of the screw placement. Inadequate decompression sometimes is reported, inferior fusion rates, and sometimes nerve root at risks and increased rate of nerve damage. So let's say a few things about that as well. This I can show you. This is a personal audit of my minimal invasive screws that have been placed over the last years. As you can see here, out of 806 screws that I have placed with minimal invasive technique, only 2 screws have been revised. And the reason for revision was pain, but no neurological deficit. So it was a marginal irritation of the nerve root only. So if you go through that table, you can see that the first screws really took a lot of time for me to place them. Average time 23 seconds. So X-ray 21 seconds. But if you can go and towards the latest placements, you can see that the average time for 2 screws is 10 minutes, and the average X-ray timing is only 7 seconds for 2 screws. I'm talking about 2 screws because I tend to follow multiple objects when I do minimal invasive, and like that, I'm trying to reduce my dose. So of course, I will not lie to you that all the screws that I place nowadays, they will fall in this part of the table. Of course, no. Sometimes you have complicated cannulation of pedicles, and you go back to towards the left side of that table. But the majority of the screws that I nowadays place, they will be close to these figures because, of course, this comes with the experience. So the simple technique that helps me with the precision of the placement of the pedicle screws is that I rotate my Jamshidi needle. I usually use beveled Jamshidi. I don't like using diamond because with the diamond, the rotation is not giving you anything. But with the bevel tip, when you rotate, you can easily achieve a couple of degrees, which is not possible to achieve with anything else. So by, as you can see here on that figure, by rotating the bevel medially, up, laterally, or down, you can achieve a couple of degrees correction. And this is giving you a good precision that I haven't been possible to achieve with anything else and with any other technique. This is a good example of the precision that you can achieve. This is a patient, this is one of the screws that I have to revise. As you can see here, the screw is touching the nerve root, and the patient was symptomatic. So I had to go back, and again with minimal invasive technique, I easily changed the trajectory. This sometimes could be very difficult because, as you know, for those who are experienced with this, they know that the screw tends to go in the same canal quite often. But with the minimal invasive technique and with rotation of the bevel, you can correct the trajectory relatively easily and achieve the trajectory you like. This is another example that, in my hands at least, the simple X-ray technique and bevel tip is working well and gives me good precision to do discal screws, which sometimes are very difficult, and the Jamshidi sometimes is following a direction that you don't like and that you don't want to go, and it could be also damaging for the structures. With this technique, I am possible to achieve precision for to do these things. So another pitfall is inadequate decompression. You can see here, I showed you that picture before with simple rotation of the retractor, whatever retractor you have, with inclination of the retractor medially and laterally, you can achieve very good decompression, and this is normally adequate for any condition that you think of. You can see here nicely decompressed exiting nerve root. You can see here traversing nerve root, and you can see the midline of the dura. Inferior fusion rates. The fusion rate is a problem with some of the minimal invasive techniques because the exposed bony structures sometimes are less than you would normally expect with the open techniques. However, I think lately that the inferior fusion rates are not because of the minimal invasive techniques, but probably because of our technique. I deliberately put here a anterior approach, and this is just before you put your cage. Let's say if you're doing corpectomy case, you can see here how nicely you have are the end plates prepared. And this is the key for fusion rates. You have to prepare your bony structures adequately, and then you will have good fusion rates. Now, in one of my cases, after I have spent 10 minutes with preparing the disc for an interbody fusion, I decided to stick an endoscope in and to see what I have achieved with the preparation of the end plate. So you can see the different standards here now. You can see on that side, up and down, this is how good I have prepared the end plate. And if you compare to that, nothing to compare. Significantly less prepared end plate comparing to what we normally see with the ACDFs or with the corpectomies. So the preparation of the end plate is for the bony structures that you would like to fuse. Whatever technique you use is important, and the fusion rates, although sometimes we blame different techniques, this is probably because of our technique. See here, that's the traversing. This is the exiting nerve root, Cambin's triangle, and we were just in the disc. So another problem that is usually reported is the nerve root at risk. Again, with modifying your techniques, you can be sure that your neural structures are intact. You can see here on the first row, this is the way how I started doing my my decompressions. And when I was doing my T-lifts initially, I was removing the bony structures from pedicle to pedicle. And this is what you can read in many books, and this is what is recommended. However, with my latest cases, I have started leaving that overhang intact. And this small piece of bone is protecting your exiting nerve root when you are treading different big instruments in the discectomy that you have performed. So for me, this was a good modification of my technique, and that has saved me a lot of headaches. If you would like to protect more, because sometimes even if you leave that overhang, you have a collapsed disc and you have really small spaces, you can gain extra protection if you simply stick 2 key wires to protect your traversing and you're exiting nerve root, and this is really good protection. And if you do that, the chances of you damaging nerve root will be slim to nil. So to recap, why we need to consider minimal invasive surgery, because that will give you less blood loss, less infections, faster recovery, shorter hospital stay for your patients. You can operate patients that you wouldn't normally operate, like obese, old. You will reduce cost for your institution, and the patients will like it, and the patient will ask for that. The minimal invasive surgery is challenging, and it may be demanding in terms of technique, in terms of learning curve, in terms of different instruments and different devices that you need. But even if you don't have everything, you can still you can think intelligently, you can generate ideas by demand, and you can still start with what you have. Thank you. Hello?
Thank you so much for this nice presentation. First of all, we have lots of participants here, but can you please stop sharing your screen so that we can see many people on video? Yeah. So we can do it like that. If anyone has any question, please open your microphone and please ask your question. Any questions?
Dr. Onur, good evening.
Hello, Dr. Mehmet. Welcome. How are you?
Yes, thank you. Thank you, Dr. Peev. That's very good presentation regarding the minimally invasive surgery. I have a contribution and also the one questions. That regarding the retractor, yes, is it okay that we are using the Meyerding or Scoville and other retractors that you showed in your slides? The one of the wedge is blade, and other side is as a nail or pin. When you put, for example, in minimally microdiscectomy,
Yes.
on a microscope that you put, and after the dissection and perivertebral dissection, if you put the Meyerding nail wedge or inside the interspinosus, that time regarding the force, maybe it causes the rupture of the interspinosus ligament.
Okay.
And of course, when we are doing the minimally invasive, of course, I believe that we should avoid to rupture the interspinosus ligament. And the other questions is regarding the radiations exposure. Yes, of course, at first time we should keep ourselves that in the avoid any radiations harmfuls. That of course very good slides. That have you any experience about the navigation used in spine?
Yes.
Because in navigation there is no radiation.
Yes, I have experience in navigation, and of course, the navigation is the next step. And of course, this is something that you have to consider using in case you have it. And that will give you very good precision. That will give you zero radiation. That will make your life easier because you shouldn't be wearing the heavy lead gowns. Of course, the navigation is good to have. But unfortunately, we don't all have this in our theaters. And that's why I wanted to give a few slides and to give alternative and to show that if you don't have navigation, that should not stop you from performing surgeries. For example, when I started with without navigation, my let's say my single level TLIF was 3 minutes screening time. But now, after this many that I have done, I'm way below than 1 minute, and this is comparable to the majority of the open surgeries. So the point is, yes, you're absolutely right. The navigation is very good to have. And I wish you all have it in your theaters and being possible to access it and to use it for your patients and mainly for you. But if you don't have it, you should still carry on. You should not stop yourself from developing yourself. That was number one. So with regards of the pins, again, I agree completely with you. If you put the sharp pin medially, which I normally do when I do decompressions, and when I do decompression, which is over the top decompression, I will put my sharp pin medially, and like that will not prevent me from gaining access medially. However, I normally, what I do is I tend to rest my pin not in between the spinous processes, but on the spinous process. What I do before I rest my my pin, I get the drill and I drill a small point where I will dock my pin, and then the drill is not moving from there and it's not disturbing the ligaments. I agree completely with you that if we do minimally invasive, we have to care about the ligaments, and the interspinous ligament is a very important stabilizer, and we have to respect that.
Sure, sure. And maybe using the tubular system, maybe that is safe with compare of the others retractors.
Absolutely. So tubular system is something that is good to use, but if you start with the tubular system, it is difficult to achieve what you would achieve normally with that. So this is something that I recommend for somebody that is starting the minimal invasive surgery, and that is a transitional point to the tubular retractors, because the tubular retractor is restricting you quite a lot, and you have to really have good experience to start with that. And before you start, this is a step to go, and I think this is a good for the juniors to start like that. They still can apply the minimal invasive principles, and this is still gonna achieve more than the open procedures in some of the cases, obviously.
Thank you.
Nikolay, there
Yes.
is one question, which is very nice question actually. What are the limitations of minimally invasive surgery? Which surgeries do you don't want to make using MIS techniques?
Okay, so
For instance, deformity, let's say deformity.
This is indeed very, very nice question, and thank you so much for asking that question. So I like that question. So, and I will answer like this. So when you start the minimal invasive technique, the minimal invasive procedures, some of the surgeries will be impossible for you to do with minimal invasive, and some will be possible. But after 2 years, the surgeries that are impossible for you to do today, in 2 years they will be possible. So I like to say that the impossible things are the possible things that need more time. That is how I will answer to that question. People are doing deformity surgeries with minimal invasive. If you go and see what Richard Fessler is doing in the States, he is doing big corrections with minimal invasive techniques. Sometimes you can use hybrid techniques. You don't need to use only minimal invasive. You should not restrict.
Okay. Onur?
Here,
Nikolay, thank
Can I
you
ask
so much
Dear Peev,
for your comments. There are lots of questions. I think Jose Antonio Sarino has any question. Yeah, please.
Peev, the title of the talk is very nice because it's talking about minimal invasive spine surgery in a center with limited resources. So my question is for the assistants is, what do you consider about the minimal conditions to make MIS procedures with maximal safe? Because it's very important. And in Latin America, in Africa, in Asia, I think even in some countries of Europe, limited resources means something absolutely different than what you are presented. In Mexico, limited resources could be a very simple OR. It's difficult. Not navigation, no arm, a very simple C-arm, etc. So I would like to know, what do you consider is the minimal conditions to make, in a safer way, minimal invasive approaches?
Actually, Nikolay has problem in connection. I can answer some of your points. Actually, he has actually shown something. He is using a hemilaminectomy retractor and wheelchair approach for pedicle screw fixation. He has shown it nicely. Actually, those retractors are in the hands of everybody. He didn't stress too much about the navigation systems. Yes, the navigation systems may diminish your X-ray uptake. So then if you use it, you will get less X-rays. But a tube system is almost necessary to be able to widen your indications. With the normal full endoscopic system, it's quite difficult and more expensive to do some lumbar spine stenosis patients, especially. Yes, with some modifications, you can still perform minimally invasive surgeries, even if you don't have navigation, even if you don't have the so-called sextant system, for instance, the Medtronic sextant system. You can make small incisions. Probably we can call such surgeries minimal access surgery instead of minimally invasive surgery. This is not full endoscopic, but still they are very less invasive surgeries, and we can apply them.
Sorry, everybody. My Zoom crashed again.
Yeah, I answered one question instead of you.
No, please. Yes, of course. Yes.
Okay.
Another question was, what do you do with if you have CSF during the surgery?
Right. Okay, that's another good question. For many times when you operate, especially when you operate all patients with significant degenerative changes, I actually do see small dural tears. Sometimes I see only the dura with the arachnoid intact. Sometimes I see the dura and the arachnoid, and I see a small amount of CSF. If it's a big dural tear, I try to put a single stitch there, or if it's a very small dural tear, I would just leave it, and I have no problems. The minimal invasive, the good thing about the minimal invasive is that you have a small access, you have not detached your muscles, and the muscles close nicely after you remove your retractors, and they prevent from significant CSF leak.
Nikolay, we have 122 participants, and there are lots of questions here. And another question is, do you tilt the operating table? Do you use loops or operating microscope from our friend Ismail Nasuri?
Yes, I don't use loops. I use microscope mainly. And the way how you use a microscope and still have a chance to use your surgical instruments is you put the microscope on a maximum focus distance. You make sure that your microscope has a good focus distance, at least 45. And yes, of course, you can manipulate the table so you can achieve better position of the patient and achieve better medial or lateral exposure with your instruments and with and better vision. Yes, I use microscope as well.
And Mohammed Rana is asking, can you tell us the tips of putting rods in the stick?
Sorry.
How do you put the rods there? How do you insert the rods here?
How
is there
do I?
tips?
How do I insert the rods?
Yeah.
Usually the system that that you use will give you will provide a specific tool for you to use the rod. So there is different minimal invasive systems. For example, the old Medtronic systems, they needed extra stabbing point to insert the rod, but all the new systems you can insert the rod through the opening that you have done for your screw. The key point is with inserting the rod, you have to make sure that the rod is under the muscles and not disturbing the muscles like that. The old systems, some of the old systems, they had very small window, so it was difficult to achieve insertion of the rod, especially if you have to address more than 2-3 levels. But the new systems, they have long windows, and this is not a problem. I used to use X-ray to position my rod with the old systems with the small windows, especially if you have to address more than a couple of levels. But now this is not necessary, and it's relatively easy.
Nikolay, another question at the beginning of this lecture was, why do we use extended legs for the retractors?
Why do I use extended legs for the retractor?
Yeah.
So, because I use that when I have big patient, when I have patient that is, let's say, the biggest patient that I have operated is BMI 50. And if you have BMI 50, you need at least 12 centimeters to go from the level of the skin to the surgical target.
Yeah.
I think.
Onur has
Sorry.
to our webinar.
Nasuri is there. Nasuri, do you wish to ask something?
Yeah, I am the one who asked the question how to tilt the table to achieve a vision where you put your screw. And I also asked the question because my microscope is down, I only have loop. Can I do the same procedure with the loop? And another problem, also, if you come from lateral, the muzzle is a bit heavy to retract it immediately. I don't know whether he has some technique of retracting the muzzle medially, and what happens to the nerve supply. And then do you have to make incision on right and then go back and do it on the left? Put the screw on the right, put the screw on the left. Do these two incisions not violate the invasiveness? You can go medially and one incision, two incisions laterally and medially.
Okay, right.
Hello.
Morja, we must give an answer to our Nigerian friend Nasiru.
Yes, I will answer if you allow me, Mehmet. So so basically, the first question was about the tilting of the table.
Right.
Of course, everything is possible. You can tilt your table left and right when you are doing your decompression. If you would like to do decompression, everything, all that is possible. So you said you're having loops only. If you are comfortable with loops, and if these are good loops, of course they will give you the quality that you need. Yes, it is not as good as probably a good microscope. For me at least, maybe for you that's not the case because I don't work with loops. But if you are working with loops and if you're comfortable with loops, why not? Many people work with loops, although they have microscope. It's a matter of how you will make yourself comfortable. So loops are alternative to microscope and not bad alternative. Depends on what works well for you in your hands. And every tilt of the table is allowed as soon as you don't down the patient from the table, of course, and you achieve the necessary goal that you have. However, I advise you not to tilt the table when you start putting your screws, because you will get yourself lost, and you will, if you start tilting the table, you will lose the good pictures that you have to have. You always should aim to have neutral pictures, straight AP, straight lateral, and this is when you will achieve good results with your screw positioning. If you start rotating the table, you will get yourself lost and you will have screw malpositions.
Thank you. Thank you very much.
Nikolay,
Nikolay, I got
we
a question.
have one more question. Is it difficult to create oblique trajectory for contralateral decompression with this type of retractor rather than tubular one? Nikolay is connected, I think. Nikolay, can you open your microphone?
Nikolay,
Yes, unmute, yes.
Yeah.
I don't know how it happened, but anyway. Yes, so.
We're hearing you now.
Hello?
Did you get the question?
Did you get the question? We didn't hear your answer.
It freezed.
Yeah, Nikolay has connection problems. I think we
Zileli,
can. Yeah.
it was really a good presentation and lots of people were interested in it. We have passed 1 hour. Maybe we have to stop it. I'd like to thank to Nikolay and also for you for giving us an opportunity at this COVID virus days. And it's a good way to have practice, to have our knowledge, to change it. I'd like to thank you and also to everyone for participating. And please, can you make the last words?
Yes. Yeah. I don't know why did it happen. Actually, Nikolay had connection problems, but we had almost 130 participants at the beginning, and I'm happy for being together with all the participants and wish to see you again in future webinars. Say goodbye to everybody.
Goodbye. Thank you so much.
Goodbye.